Welcome to the Dr. Lexi Show, where I take pregnancy topics and break it down into simple terms to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal-fetal medicine specialist, which just means a high-risk pregnancy doctor. And in honor of Prematurity Awareness Day and basically International Prematurity Day, it sounds like, in the month of November, we are going to talk about prematurity. So expand our knowledge. I'm not going to go into a lot of great detail, but this is the point about this. In the United States, approximately 10% of pregnancies end in a premature delivery. Okay. That doesn't sound like a lot. Maybe if you're like, oh, well, then 90% don't. But man, oh man, 10% is not a small number in my world. Okay. So then the question is of premature deliveries, two big questions. Number one, what makes a preterm delivery? If it happens prior to 37 weeks and 0 days, that is considered premature. Okay. That's the delineation we use. Now, then the second question is, well, are all premature deliveries created equal? And the answer is no. So we know that of deliveries in the United States, 10% are premature. Okay, now let's take that number and let's say of those that are premature, how many of those are due to being in spontaneous labor or having a spontaneous preterm birth? That's approximately 50% of that 10%. Okay, so of that 10%, the premature deliveries, what percent is due to ruptured membranes? That's about 30%. Okay, so now we've gotten up to 80%. The remaining 20% are due to medical indications, really bad diabetes, terrible preeclampsia that has these things called severe features, maybe really bad cholestasis of pregnancy, other things that are happening that are called medically indicated deliveries. All right, so what we're focusing on today, we're going to move into developing some skills. I'm going to talk about how I would counsel someone who comes into me who says, I had a prior spontaneous preterm birth. Okay, meaning it happened due to they had preterm labor. So for those patients, it's really important, and it'd be nice if you can actually be able to see someone prior to a future birth. So that's called a preconception consultation. I do those all the time. I love doing them. Check out the website if you want one, right? Okay, so that's important to do. Now, here's the big thing. If you have had a prior spontaneous preterm birth in a future pregnancy, here is generally what is recommended. Now, this is a generalization. Everybody's individualized. Cervical length screening to look at the length of the cervix. Okay, so right here, from here to here. This is a model, but still, the length of the cervix. This whole thing is the uterus. The lower part is the cervix. So we're looking for this length here. From the internal os to the external os, we want that length to be long and closed. Well, what is long and closed? Long is considered anything above 2.5 centimeters or 25 millimeters. Now, the debates are coming. Hold on one second. Need more coffee. Studies are kind of all over the place, but as of now, it's 2025, late 2025, almost 2026, 2.5 centimeters. We want the cervical length to be above that. Now, so here's the plan. If you had a spontaneous preterm birth before, we want to look at the length of that cervix sometime between 16 and the 23rd completed week. So anytime between there is fine. We don't want to look after 24 weeks because we wouldn't intervene. Okay, so now that you know that cervical length screening from 16th week to the 23rd week is recommended, what do we do if we see a short cervix, i.e., what if the cervix is less than 2.5 centimeters? Two options, vaginal progesterone at night or a cerclage, which is sewing of the cervix to try to keep it shut. And a cerclage, we typically try to put it right at as high as we can get for that length of the cervix. So if the cervix is shorter, we don't have as much cervical length to work with. That's an outpatient procedure. You usually go home the same day. So those are the options. Now, if you're thinking, well, in a prior pregnancy, because I've had preterm birth before, they put me on intramuscular progesterone. Great question. Taken off the market. FDA pulled that. So we don't have that as an option anymore. You may be thinking subset, well, what if I had a prior spontaneous preterm birth and they offered me out the gate vaginal progesterone? Individualized, can be considered. And sometimes people utilize how early was that last premature delivery. Okay. So those are things to think about with that. So also a fun fact, if you had prior ruptured membranes that led to a preterm birth that was prior to 37 weeks, general consensus right now is we treat that kind of like you had prior spontaneous preterm birth, and you can have the option then of doing cervical length screening from that 16th week to the 23rd week of your pregnancy, and if it is short, intervening. So that's a consideration. Again, with the side note of the possibility of doing vaginal progesterone earlier on, individualized care with you and your doctor to decide if that's something you want to do. Studies still ongoing right now about vaginal progesterone to see when to use it. Again, intramuscular progesterone, the brand name for the main one was called McKenna. We don't use that anymore. Now, impact here, we are trying to decrease that 10% risk, right, across the board in the United States. And for you individually, if you have had a prior spontaneous preterm birth, we're trying to prevent you from having another spontaneous preterm birth. Okay, so that's the impact we're trying to have. The questions you can ask: cervical link screening, when should I start it? Where do I go to do it? Will it be a transvaginal ultrasound? Those are meant to be better at seeing the cervix because it goes inside the vagina to actually try to see the cervix very directly. It doesn't go into the cervix, okay? So transvaginal ultrasound, it's like if the vagina were down here, the probe would go, I got a pin here, 1 second. The probe, which is bigger than this, would go into the vagina and try to go into what we call the posterior fornix, so behind the cervix, and it looks at the length of the cervix directly. Okay, it's the best way to measure that cervical length. So ask, when would I start those? Where am I getting them done? Will they be done transvaginally? And do we have a plan for if my cervix is less than 2.5 centimeters, what's the next step? General summary rule of thumb here. For someone with a history of spontaneous preterm birth, ask your provider, when can I start my cervical length screening? Should start around 16 weeks. Where am I going for that? Am I a candidate for vaginal progesterone now? And then what are we going to do if my cervix is short, less than 2.5 centimeters, on a cervical link screen sometime from the 16th to within the 23rd week of gestation? All right, I hope that stuff helps a little bit. Arm yourself with advocacy across the board. If you do need a preconception consultation, or you're between pregnancies, or you're in a pregnancy and you have a question, feel free to look me up and get a consult. That's what I do. I'm licensed in half the states across the US. And if I'm not licensed in the one that you're in, we'll find you one. And I have someone that can help you out to get that consultation done. I hope this was helpful. I'm Dr. Lexi, wishing you a happy and healthy pregnancy. Do you want to say something? Nothing?